Anyway, you all had many questions about this whole concept about inflammation, about discs regressing, and so I'm going to, let's see, yes, okay. So, so this all really begins with understanding this concept of contained versus uncontained, and the fact that it is directly related to clinical response. And it's completely the opposite of what I and many of my colleagues learned, maybe even what many of you folks learned in school, because I never learned about disc resorption. This is now a well-accepted fact. It started out in many case reports when patients were beginning to have MRIs that imaged their discs, and then at some point in time, for whatever reason, later on, the same patient, the same spine was imaged, and there was obviously something different about it. There are reports in the medical literature. We have a number of reports in the chiropractic literature about how certain chiropractic techniques sucked discs back in. Well, we now know that that was a misunderstanding about what was going on, and Dr. Jim Cox, we've talked with Jim Cox several times about this, and he said, yes, he admits that that was a mistake he made early on, feeling that perhaps flexion distraction sucked the disc back in. It does not, and we now all know that thinking that some form of treatment causes disc material to go back into the intervertebral disc space is completely wrong. We now know that this is the natural history of disc herniation. And this happens whether we want it to happen or not. It does, and it happens in spite of most treatments, mostly not because of a certain treatment. The disc material herniates. As Peg said, it's perceived as a foreign object, and therefore our body does what it does. It creates an inflammatory response. And so granulation tissue surrounds it. This granulation tissue ideally is well supplied with macrophages whose job is to engulf bits of this disc material and carry it away. And so this is how things resorb. At the end of the day, there is a scarring over process that occurs, and and yes, the disc is not normal, but the herniation, the bulk of this foreign material is no longer there. I'm going to get into this a little bit more. Hopefully we'll have time for some interactions. I also plan on going into what we as chiropractors can do to maximize this process, because we like to let the body heal itself, right? That's our culture, that's our philosophy, that's our mission. And so what can we do to support this process? There are many things that we can do. Some is based on evidence. Some, I will tell you right up front, is based on speculation. I also want to tell you right up front that this is not based on getting MRIs of your patients. You do not, I agree with Dr. Till, we do not need to get MRIs. In fact, most of the time we don't even need plain films of these patients. We have the capability of diagnosing their condition. We have a high suspicion that this is what they have, a disc herniation. We can usually tell what level it is based on our history and clinical exams, and we can begin treatment, especially when we understand the physiology of what's happening. Then we can support that and we can follow that patient's progress. The other thing we can do that's very important is to make sure to communicate this to the patients, because patients may be getting other communications from family members, from other health professionals, and so it's important that you feel comfortable being able to confidently communicate what to expect through this process. So I'm going to share with you some of the best articles for you to track down. They are old, and so you should be able to get many of these. Spine, unfortunately, still has quite a paywall, but hopefully, especially those of you at school or through, if you're alumni of certain schools, many times the school will help you get full text articles on these, because these are helpful for you to be able to understand in depth. I'm a reader. I'm one of those people that I have to read the originals. Abstracts just don't work for me, and so I encourage you to do likewise. This is one of the first ones. These are all in Spine Journal, as I mentioned earlier, very prestigious international journal, highly peer-reviewed, so you can be confident that these are not just speculations of some people off in some part of the world, although you will notice that most of these are Japanese researchers. Japanese, or I think one of them is a Taiwanese group. For whatever reason, they had quite a curiosity, much greater curiosity than we had in the States, where I don't know how many discs are removed in a year. It's hundreds of thousands of disc material is pulled out of spines in the United States every year, and nobody ever bothered to look at it, to really see what it was. We also, once we began doing MRIs on patients, nobody really did the follow-up that was necessary to be able to get a good understanding. So this is a group that includes researchers and pathologists and radiologists who were trying to understand, what is this material, this herniated nucleus pulposus, as Peg said, HNP, even though that's been a common acronym, it's really not appropriate, and Fardin and Millett said that it really should not be used. It's an inappropriate acronym because it doesn't correctly describe what's going on. But anyway, you can see back in '96, before the consensus statement was published, HNP was certainly still being used. Another good, very good one was the pathologists who did a lot of work and who verified that much of the bulk of that herniated disc that was seen on the MRIs and that was pulled out at surgery actually is granulation tissue. It's an inflammatory response of the body. It's not all disc material. And I'll give you some examples of that shortly. And then perhaps one of the best ones is this article from 2000. And this is the one that really helped to solidify the whole concept of contained versus non-contained. In this case, they called it transligamentous extension, which is maybe a better technical term than contained versus non-contained. But they're the ones that identified that those discs, those herniated discs that extended through the ligament were much more likely to heal more rapidly. And they also verified that the larger the disc herniation on MRI, the more rapidly and more completely the condition responded to conservative care. And so that's what flipped me out when I learned about it, because yes, I always thought, oh, this big, huge disc herniation, gotta have surgery, can't do anything about that, it's a danger to have that in your spine. No. And so I've been able to tell patients that who come in, and in fact, I remember one patient very clearly who came in and he had evidence of disc herniation. I had treated him for a while. He was making progress, but his family insisted that he go see the orthopedic surgeon, had the MRI, and was told, you have a huge disc herniation largest he'd ever seen. I think that's a phrase that many of the surgeons learn as part of their residencies. Everything's the largest, right? Whether they're gallstones or whatever. Anyway, and so he was scheduled to have surgery. Once again, wasn't able to have it immediately. Had to get into the rotation there, and so. Thankfully, the patient thought, well, I'm going to come back and see Dr. Hyland again. He seemed like a reasonable guy, and maybe he can at least help keep me comfortable until I have to have surgery. I have had a philosophy that people should have prehab. Even if you're going to get spinal surgery, you should be seeing a chiropractor who can help keep your spine mobile and functional beforehand, who can give you things to do beforehand as far as exercises, keep you active, and who can do some soft tissue work on you before you have to go in and have surgery. That certainly will help the surgery go better, and it'll help the post-surgical rehab go better. So he came back in, and he was obviously down in the dumps, and he said, oh, no, I'm going to have to go in and have surgery. And I said, really? He said, yeah, the surgeon said it was the biggest one he'd ever seen. And I said, that's fabulous. He goes, what? I said, yes, the current research now has confirmed that you are much more likely to heal completely and more rapidly if you have a large herniation. Get those images in here. Let's take a look at them. And he was right. It was a pretty big one. But you know what? He decided to cancel the surgery. And he did. He got better. He responded to conservative care. And that's because this article right here, thankfully, I had seen this and had come to an understanding, already had a concept of this whole inflammatory process, but it's something that you need to be able to share with your patients. Now, based on that, several orthopedic surgeons in Japan said, well, why are we doing so many disc surgeries then? The literature is starting to say that many patients don't seem to need surgery. They were a group of orthopedic surgeons who pretty much specialized in disc surgeries, and so they received referrals from GPs and all sorts of MDs for disc surgeries, and so they would do several hundred disc surgeries a year between I think it was four surgeons. And they said, well, let's try something different. Let's see if this stuff really works. And so they developed a new surgical protocol. So for 2 years, they tracked all the patients that were sent into their practice for discectomy. It turned out to be 390 of them. As I said, a pretty successful orthopedic spine practice. And so they tracked these 390 patients, and they put them into a new protocol. Their protocol was no surgery for 2 months. Normally, once the patient came in, they reviewed the images, they did their exam on the patient, they would then schedule the patient for a discectomy. And they said, no, we're not going to do it for 2 months. Unless, so they did have, if there was progressive neurological deficit, cauda equina syndrome, or intolerable pain. And obviously that last one's a little bit squishy. We'll talk a little bit more about that. And so what did they do instead? They did conservative care. Now, I would have said they could have done a better job with conservative care. Bed rest, as we know, is not really something, but if you're in a lot of pain, sometimes you can't do a whole lot more. I think with proper education and encouragement, I've had many patients stay quite active with acute disc herniations. So that was their conservative care program. Okay, nothing great. If necessary, if the pain was so bad that they were having problems and that the patients were considering surgery, then they would do nerve root blocks. That is an injection of anesthesia, an anesthetic agent, oftentimes 2 agents, a short-acting and a long-acting agent, right around the affected nerve root, the inflamed nerve root. Obviously, something like that wouldn't do a whole lot for an actually compressed nerve root, but it does do quite a bit for an actively inflamed nerve root. Or, if necessary, if it was terrible, they would actually do an epidural injection, the sort of thing that women are given if they're in terrible pain during delivery. And so obviously those people would not be able to continue to function very well. And as a matter of fact, they would put them in the hospital for pain control, if necessary. So out of the 390 patients, they reported that they did have to put 69 patients in hospital in order to control their pain within the first 2 months. At the end of 2 months, then they reassessed and asked the patients, okay, how are you doing? The vast majority were getting significantly better. A few of them were still kind of, and so they said, well, they offered to do surgery. You were sent here for surgery, so we'll do surgery on you. What was the percentage of patients that ended up getting surgery after just 2 months of waiting? It was less than 10%. 35 patients ended up going to surgery. One of the things that they required of the members of the group was that if you're going to go in and do surgery, you must detail very carefully whether you have to go through the posterior longitudinal ligament to remove that disc. It's hardly ever even reported in discectomy surgical notes. They just go in there and slice through whatever they need to and pull it out. But here they had to carefully dissect out the disc material. And if they had to cut through the posterior longitudinal ligament, it was reported. What they found was that of those 35 discectomies that they still had to do, 91% of them were contained. So their conclusion was that, gee, if people have uncontained, so they said we support the literature that's already been reported, the authors believe that patients with non-contained lumbar disc herniations can be treated without surgery if these patients can tolerate symptoms for the first 2 months. Now, that's a little bit optimistic. I'm sure you've all had patients who have tried to tough it out, and it goes beyond 2 months. But the good news is that if you can work with them, if they have a cooperative employer, let's say, if they have some sort of short-term disability insurance, if they have some way to continue to make a living during this time, support a family, whatever they have to do, and if they are provided with appropriate pain control, which many times, at least in the States, is not available to them. I mean, I don't know any insurer that would allow a patient to be hospitalized because they have a disc herniation. And some of these patients were hospitalized for weeks for their pain control. And so, yes, that's kind of expensive to put somebody in hospital for 2 weeks, but that's ends up being cheaper than actually going through the whole surgery, paying for the surgical suite and the surgeon and such. Anyway, so, and you can see, look at the date on this, 2001. So this is not new information. This has been out there for a while. It's soon going to be 20 years since we now have not just the pathological information from those original reports, 96, 97, and such, but we now actually have a nice, very nice trial here. It's not a randomized trial. It's very hard to randomize disc patients, to randomize humans for anything. But they had a comparison because they could look back and they could see that in previous years, it was the flip. It was more than 80% of the patients that were sent into them for discectomies received a discectomy. So that's quite a difference. All right, here's another way to look at this. Let's take a case report. Now, case reports are not the pinnacle of research. I recognize that. Case reports help point us in directions. They can also help validate certain constructs, certain ways of looking at things. This is one of the best case reports I've ever run into. Also published in Spine. It's called Multiple Independent, Sequential, and Spontaneously Resolving Lumbar Intervertebral Disc Herniations, a Case Report. And it's particularly nice because it's about a medical doctor. That's the patient. That's the case that's being reported on. And so he had all the capabilities available to him for whatever treatment he needed. So, yeah, he's had back pain for 10 plus years. Recently, though, it's gotten worse, and he's got some radiation into the posterior thigh. Neurologic examination showed weakness of the left extensor hallucis longus, rated 4/5 by manual motor testing. The results for the remainder of the neurologic examination, including sensory function, reflexes, and a straight leg raise, were normal. So, because of the persistent symptoms, at about 4 weeks from onset of symptoms, an MRI of the lumbar spine was obtained. And I will apologize for these. These are scans of the article as published in Spine, and so the axials were just terrible. I couldn't even show you those. But anyway, so you will see at least poor quality mid-sagittal images of these. And so the description was a large intervertebral disc herniation in the left paracentral region of the spinal canal at L4, L5, consistent with the patient's left L5 radiculopathy. The unusual size of the disc herniation led to the administration of gadolinium to confirm the diagnosis. So yes, it's a big one. I don't know if it's the biggest they'd ever seen, but obviously they think it had unusual size. After a discussion of treatment options, medical management was continued, which included a course of oral steroids, followed by non-steroidal anti-inflammatory medication. Over the next several weeks, while continuing to work, the patient's pain, spasms, and weakness completely resolved. So, how long did it take for this to resolve? Several weeks. What did he do? He continued to work, so stayed active, no bed rest here. Yeah, did oral steroids, so no injections of steroids in there, but did oral steroids. So, great. He's happy. It's gone. His symptoms are gone. That's fine. Then, in September of 1996, so that's not that much after this, the patient experienced low back pain and new onset of right leg pain. Remember the last time was left. Right leg pain in the L4 dermatomal distribution. His left leg remained completely asymptomatic. He ambulated in a squatting position with flexion at the hips and knees because this was the position of comfort. At other times, he used a wheelchair. He was always able to obtain a position of comfort, and he was able to continue to work. Hi, I'm your doctor. Follow me. I mean, you know, you just got to enjoy these things when you read them. It's like, wow, what a visual that was. Neurologic examination results were normal, and tension signs were absent. So he's not even got the standard things that we think of as solid evidence of radiculopathy. An MRI of the lumbar spine demonstrated a moderate size right paracentral intervertebral disc herniation at L3, L4. There it went, okay. L3, L4, consistent with the patient's clinical syndrome of an L4 radiculitis. The previously demonstrated disc herniation at L4, L5 had completely resolved. After several additional weeks of medical management, the right L4 radicular symptoms completely resolved. He knew what to do. It had worked before, so he kept working, and it went away. A couple of years later, in September of 1998, new onset of low back pain and right leg symptoms developed. These symptoms were distinctly different from the previous right side symptoms. They were associated with diminished sensation in the plantar aspect of the right foot and gastrocnemius weakness manifested by an inability to toe walk. The right Achilles deep tendon reflex was now absent. The results from the straight leg raise test were negative bilateral. I gotta wonder if they even knew how to do a straight leg raise test on this guy, you know? I mean, really? Okay, but always had a negative straight leg raise test, it seems. After several weeks of persistent symptoms, an MRI of the lumbar spine was obtained. The MRI demonstrated a large intervertebral disc herniation in the paracentral region of the spinal canal inferior to the right L5 pedicle. This appeared to arise from the L4, L5 intervertebral disc space with distal migration. The previously visualized and symptomatic intervertebral disc herniation L3, L4 had completely resolved. So yeah, L3, 4 is gone. And now look at this huge thing. And it's coming out of the same disc that had the first huge thing. I mean, do you have that much disc material in a disc? No. And that is confirmation that these things are not all disc material. After several additional weeks of medical management with a course of oral steroids followed by nonsteroidal anti-inflammatory medication for the S1 radiculopathy, the symptoms completely resolved. At this writing, the patient has remained without radicular symptoms since that time. So this was published in 2002. So about 4 years later, probably 3 years with publication time, although he has experienced some right calf cramping and intermittent low back pain. In October 1999, because he wanted to publish an article, no, it doesn't say that, but we don't know why, but he was interested because he hadn't had any problems for now more than a year. October of 1999, while the patient remained asymptomatic, an MRI of the lumbar spine was obtained to visualize the lumbar spinal canal and assess the intervertebral disc spaces and cauda equina. There it is. The MRI demonstrated complete resolution of the most recently symptomatic intervertebral disc herniation. From under the right L5 pedicle, there was no evidence of nerve root compression by the intervertebral disc material at any level of the lumbar spine. Discussion. So, yes. The reported patient's case history demonstrates 3 sequential, independent, and spontaneously resolving lumbar intervertebral disc herniations. As per the patient's choice, he was a medical doctor. He played with those orthopedic surgeons on the golf course. He wasn't going to let them touch his spine, right? Each event was managed non-operatively, and as shown on MRI, each demonstrated full remission in both the abatement of radicular symptoms and the anatomic resolution of the intervertebral disc herniations. And then this goes on with a very nice review of the literature. Spontaneous reductions of lumbar and cervical disc herniations have been described numerous times. And they have a list of, I can't even, it's more like a dozen reports in the scientific literature. Accompanying these reductions also has been reduction in symptoms such as acute back pain and sciatica. Saul and Saul demonstrated that lumbar disc herniation with radiculopathy can be successfully treated non-operatively, with non-operative treatment resulting in good to excellent outcomes for approximately 90% of patients. Saul and Saul concluded that extrusion was not an adequate indication for surgical intervention. Several studies of the lumbar spine using MRI have demonstrated the largest lumbar intervertebral disc herniations are those most likely to show the greatest regression in size over time. And they quote On and On study that we saw, as well as another one that had reported on that. This phenomenon has been reported with cervical herniations as well. So another study that has shown the same thing in cervical herniations. The bigger they are, the more likely they are to regress and resolve. Anyway, so studies have shown that the degree of reduction in disc size, as evidenced by MRI, correlates closely with the degree of clinical improvement. So, let's see, a little bit more here. As evidenced by MRI, the reported patient's intervertebral disc herniations were extremely large. He was a good inflamer, apparently. He did a good job. He stayed active, and so his body mounted a good response. That was large. But anyway, it says this patient's intervertebral disc herniations were extremely large, occupying a major portion of the spinal canal, which is also quite large, something Peg mentioned earlier, and we'll talk about more tomorrow. There's no doubt that prognosis is in part dependent on how much space is available for the body to do this process. If somebody has a tight canal, then it's going to be tougher for them to do that. Anyway, and they go on and on into the same physiological information, the path studies. Histologic evidence has shown a greater percentage of disc herniations through the posterior longitudinal ligament contained infiltration of macrophages than those not extruded through the posterior longitudinal ligament. And so that's why we certainly know. Anyway, the reported case reaffirms earlier findings demonstrating that a large number of lumbar disc extrusions can be managed successfully by non-operative methods. So, this is a great one to share with patients, because they can understand this sort of thing. But it also is very instructive from the standpoint that it gives us some ideas as far as time frames. It also confirms the idea that having a large canal is quite beneficial. And so when people say, well, how long is it going to take, Doc? I can point to this and say anywhere from several weeks to maybe a couple of months. That's what the literature shows. Yes, questions? So, no, was there any report of what type of cortisone was used and for how long? There wasn't. It was just... And the dose, no, that wasn't reported in the case report. And obviously that would be something up to the practitioner. Now, and as I said, that's something that I would probably disagree with. Although he was doing oral corticosteroids, he didn't receive injections or infiltrations. So, this is what we have here, is these 4 MRIs, and we're able to follow this one patient sequentially through 3 different disc herniations. Dr. Till.
So presumably the extruded material had been phagocytosed.
It disappeared somehow, didn't it?
Yeah.
Yes.
And just eyeballing the height of those disc spaces, was there a measurable difference before and after the extrusion of the disc material? Because just looking at them, for what it's worth, they seem to retain their height. That's my impression, anyhow.
Yeah,
so
neither.
What kept those vertebrae apart?
Well, so neither of them are normal. I think we could agree with that. And what's going on with him here? He's also got modic changes. Remember, he's had 10 years of intermittent low back pain. And so, but yes, you're absolutely right. Considering the amount of material that's supposedly herniated out from there, there should be nothing left to hold up the disc. They're not normal height by any means, but the amount of disc material that was lost, well, certainly if we compare it to the one above, they're maybe half size or something like that. They have lost some height, but yes, they're not bone on bone, which I've heard some patients say that doctors will tell them that, it's going to end up being bone on bone. You've lost so much disc material from there, but that obviously doesn't occur. There was somebody else?
What exactly was the mechanism of injury of the second incident at that one level?
Yeah, I don't know that it mentioned any. It just, so the second one just said, in September 1996, the patient experienced low back pain and new onset of right leg pain in the L4 dermatomal distribution. His left leg remained completely asymptomatic. That's when he ambulated in the squatting position. But yeah, there was no indication of what the onset was. He was continuing to work. He was a hardworking medical doctor, and with chronic back problems to start with. He didn't see a chiropractor. And so yeah.
I mean, I think what I'm also trying to ask is if you'd already had a disc extrusion, I mean, what was that second lot of material that was basically a second herniation?
So it was a different disc.
Sorry, I thought you mentioned it was the same disc.
No, the second one was a different disc. The third one was from the same disc.
And the third, yeah.
but it came from to the other side. So it didn't even come through the original fissure, which meant that he had successfully scarred over that first fissure from May of 96. And so September of 98, he had failure, he had structural failure, biomechanical failure at the same disc through a different fissure.
And then, sorry, one last question. Apart from contained and not contained, are there any other factors that people have figured out why you would end up having an operation? Why you would not have as good a healing response or resorption linked to this sort of injury?
So you're absolutely right. The contained does seem to be one of the major factors because it doesn't allow the body to do this process because the disc material is enough of an irritant to cause the pain and the radiculitis, but there's not enough availability of that material to the body's healing response to really get a good active response. As far as other factors, well, we've already said size of canal is certainly there. And then the other reason that people get surgery is because they can't stand it. They don't want to take time off. They don't want to take painkillers or have anesthetic injections. They want the thing out. And they get, in with the surgeon and says, well, yes, I can cure you. We can just take that right out next week. And now, of course, there's Band-Aid surgery, right? The microdiscectomies where they just make a little tiny hole and they can tell them you won't even have a scar. Nobody will even know that you had this. Peg will give you a nice example of one of those. Who's next? Yes.
Go. So this might be completely obvious, stating the obvious, but when you look at all of that, you obviously only need the teeniest little bit of disc material to be seen as a foreign object, massive inflammatory response, which then accounts for the fact that there's still disc space. And maybe speaking to what Marie was asking about autoimmune disease or an inflammatory condition, perhaps the state of the person nutritionally and from an inflammation point of view, the more inflamed you are, the bigger the response, possibly. Or the opposite way around, the better state you're in, the body might launch a bigger attack because it can. It's not fighting all the other stuff going on in the body because you're eating well, sleeping well, drinking enough water.
So yes.
Pinotage.
Right. Luckily, they were out at Pinotage at our restaurant last night. I was left with Cabernet Sauvignon. Sorry, but
no shame. So you had the inferior quality.
a different experience than what Dr. Hyde had. No, but you're absolutely right. There are many factors involved here that have to do with the patient's overall health, their status of their immune system in general. Can it mount a proper response, or does it mount some sort of ineffective response? And what else is being done? Certainly staying active. We've talked about how, Peg mentioned how you need to have a proper circulation, and you need to have proper lymphatic drainage in order for this process to occur. Otherwise, you get stasis, you get buildup of edema there, which just makes the problem worse. And so one of the things that helped this guy is he stayed upright and mobile. He didn't lay down in bed. He didn't put a brace on and stop the movement there. Because as we know, the lymphatic system needs movement. It needs muscle contraction. So we'll get into that in a bit here about treatment, what we can do as chiropractors to treat this. We'll take a few more. We've got a lot of them here. You've had yours up for quite... Oh, and you've got the mic there. That's what's important.
I wanted to find out, in practice, when I've seen disc regression, it's mostly been in the first 6 to 12 weeks. So with our local neurosurgeons, it often takes 3 months for them to get an appointment. So we kind of monitor them up, and up until about 2 weeks prior to the appointment, we then do a reassessment and then either cancel or keep the appointment. But my question is, what is the time frame after a disc herniates when the chance of it actually regressing? Is it going to happen in 6 months afterwards? The guy that's gone through every possible form of treatment and eventually has crawled into you as a desperate last measure, but he's still got symptoms 6 months later.
And that's a great concern because we all will have those patients come into us, and we have to be able to answer them honestly whether we can help them or not. Of course, that's the sort of thing that there is no literature on, and so we have to look at it. Once again, it's going to depend on the patient. Yes, if it's gone on for 6 months, the likelihood of it resolving does go down pretty quickly. We would like to see it resolve within the first 4 to 8 to maybe 12 weeks. Yes, 3 months is certainly reasonable. Ito's group found 2 months. Many of them were gone. Now, obviously, that was 2 months. That was 2 months after they had been referred in for surgery by their GP. So that wasn't 2 months from onset, and so it probably was closer to 3 months for most of those patients. But certainly, I would say it's worth a try. It's certainly worth a try. We're going to talk about some things that we can do. Getting the patient up and moving around, doing spinal manipulation, mobilization, and manipulation, I believe is helpful. And we'll talk about the evidence for that tomorrow. And so perhaps at least initially, a low-inflammatory diet, but then there are some things I've used successfully with quite a few patients and several chiropractors, proteolytic enzymes. These are enzymes that are taken by the mouth that are designed to break up proteins and may help the macrophages do their job. I don't know if they ever get there. Once again, it's one of those things that there's no evidence for. I certainly have anecdotal evidence, and so I usually tell a patient it's worth trying, and I certainly would in someone who's had it for a while. I gave this lecture in Montana a few years back, and a chiropractor came up, and he said, well, I want to tell you that I had been fighting a disc herniation for more than 4 months. I didn't want to have surgery. And then one of my friends who had been to one of your previous lectures told me about proteolytic enzymes. And I started taking them. He said within 2 weeks, I felt a whole lot better. And that was after he had been dealing with this as a chiropractor for more than 4 months. So it's worth trying. Let me go through a little bit more, and then I'll take some more questions.
Can I ask one quick question?
Sure.
That the whole process that we've always had that we always taught that you explain to the patient the foot on the hose pipe story causing the compression. Now, if that's not the case and it's the inflammation, what is the physiology behind that inflammation that causes the drop foot? If it's not a compression of that nerve,
No.
How does that inflammatory reaction cause a drop foot?
So it's interesting. We don't really know what causes the malfunction in the nerves, but most of the time it's not compression. Compression of a nerve really causes numbness and complete loss of function. It doesn't usually cause pain, radiculitis, muscle spasm, those sorts of things. And so I think the thinking now is that it's very seldom. In fact, there actually have been some interesting studies done, unfortunately not on humans, fortunately, if you were one of the subjects, but animal studies where they have compressed the nerve as it comes out of the lumbar spine, and they've found that it doesn't cause the sorts of things that we would expect from the foot on the hose theory, and that it actually, and then the other thing they can do is just infiltrate some irritating substances around there, and that causes the symptoms, that causes the signs that we see. So we do have to take a new look at this, no doubt about it, but now we've got this understanding, and it's well supported now by both basic science and research and these sort of case reports, historical stuff. So what can we do? How do we help? Can I come back after I talk about this and you'll be the first to ask me a question? I'm fine to do that, but it may even be answered here. So what would we consider to be non-surgical disc care? And I'll tell you that there's not much in the way of research. There's a lots and lots of anecdotal stuff. The more I talk to chiropractors, the more they tell me about patients who they've had, and they go, I wondered why did they get better so quickly, and what happened there? So yes, there are a lot of things that we can do. Obviously, what we want to do is help them when it's acute. We want to help them with their pain control. because that will keep them from saying, I got to have this thing out. I got to see a surgeon. And so if we can help to maintain that, what can we do naturally? Well, cryotherapy, electrotherapy, massage, mobilization, acupuncture, over-the-counter medications like non-steroidals, whatever you feel comfortable with is appropriate. Now, I realize cryotherapy is kind of silly because how are you going to cool down that disc? And you don't even really want to cool it down if it's inflamed, right? No, I use cryotherapy over the inflamed nerve root. And so track down the nerve root, and you can usually find where that is with palpatory skills that we chiropractors have, and then have the patient put ice on that, do cryotherapy there. We may want to, once they're a bit farther along the acute phase, I will then start doing contrast using some heat, because remember what we want? We want blood flow. We want lymphatic drainage. And so we're not trying to stop the flow there, but initially cryotherapy may be helpful from a pain relief standpoint. It does slow down the transmission of nociceptors. And so if we can do that, we can maybe help the patient with their pain. So it's whatever you feel comfortable with using whatever. If you use electrotherapy, I used interferential, but this was 10 years ago when I was still in practice. I've been working full-time at the National Board for 10 years, so I haven't kept up with all the latest stuff. Would laser be helpful? Quite possibly, might be helpful for pain control. I don't know if we could get the light down there to the disc. That's one question. Your idea of infrared light for stimulating disc health, but how do you get it down there? How deep can that go? Can it go actually through the spine? Would you have to go laterally so it doesn't have to go through the posterior elements? I'm not sure. If you feel comfortable, if you have a good relationship with in the States, it's usually a physiatrist that does this. Refer the patient for anesthetic injections. The anesthetic being delivered around the nerve root can help tremendously with the pain. And it's not going to interfere with the healing process, with the inflammatory response, and it will actually help the patient be able to stay mobile. Low inflammation foods. We do know that much of our society is on a very high inflammatory diet, processed foods especially. Many of the refined carbohydrates, those sorts of things, are high inflammatory foods. And so it might be helpful, as we were talking earlier, about balancing out the patient's immune system, that maybe if we could get them to eat a better diet or a healthier diet or something that might help balance their immune system, that could be helpful. I mentioned proteolytic enzymes. Also something that, talk to some of your supplement vendors. Most of them that sell to chiropractors have a product with proteolytic enzymes. It's some type of anti-inflammatory product that can be used. How much do you use? No research for that either. It's basically as much as the patient can tolerate. If it interferes with their digestion, obviously they may be getting too much, but there doesn't seem to be any downside to adding extra protein digesting enzymes to somebody's diet. Adjustments. I'm going to get into that tomorrow. I'm going to talk specifically about what the literature shows about what chiropractors can do with their hands in their offices to try and help on this. And then rehab, I do have a little bit of rehab stuff that I'm going to try and just go through very quickly, and then I'll take questions. So disc rehab, there are some things that we can do to help blood flow and lymphatic drainage, and my number one is walking. I got patients walking. Once I learned about this stuff and realized, I had heard, bed rest is no good anymore. It's like, yeah, well, what does that mean? What do we do instead? And so what you do instead, what I did, is I got my patients walking. As quickly as you can, you want to get your patients up and get them walking. We want to get mobility in that area. So adjustments, and you can have your patients self-mobilize. Gentle self-mobilization so that they don't just lock all up, and that interferes with circulation, both vascular and lymphatic. And then eventually, in order to prevent what happened to this guy, they're going to need to do some spinal stabilization. Obviously, there is something abnormal in their spine. Their discs are under excessive structural pressure, and so what can we do to try and help that? Exercises. In some cases, patients will benefit from orthotics. That may just be the shock-absorbing capacity of it, but otherwise it may be improving their lower extremity biomechanics, thereby reducing some of the chronic stress on their discs. And just a brief thing about walking, why is that helpful? Just having those muscles contract, relax is very helpful. There's also a neurological stimulus. It's part of the cross-crawl process when a patient is walking, so that'll help to normalize, decrease some of the reverberating pain circuits they have. There are psychological benefits. Once a patient can get up and start moving, if they can walk to the bathroom, they are a whole lot happier, and they start feeling better pretty quickly. And then, of course, there's a future value of wellness. If you can get a patient understanding how good they feel with a walking program, then they're going to have a healthier spine. And we do know, there has been research that shows that when patients have back problems, they don't walk normally. They walk with decreased rotation. They walk kind of like this. They don't and so I encourage my patients not just to walk, but to walk with a slightly exaggerated arm swing. To them, it seems like it's an incredibly exaggerated arm swing. But for me, this is what walking should be. You should have a nice little cross crawl going on. You should have the spine doing this back and forth movement. That's what we want. Then those muscles are contract, relax, contract, relax, contract, relax, pumping the lymphatics through the area. The lower extremities are contracting the muscles there, pumping the lymph up and along. And so this is the sort of thing we want to have happening. So try and get that nice movement with your patients that may be a little bit difficult. Self-mobilization, we'll talk a little bit about that tomorrow. The simplest one is just kind of the Mackenzie sort of thing where you put hands. I would just have my patients stand up and just do gentle self-mobilization. They're usually already somewhat flexed like this, and so they would just be here, stand up, slightly wide stance, and just move it. Just work it back and forth. Pump that area a little bit to help things moving around. I'm not going to get into exercises or orthotics. The rehab stuff is beyond me, but certainly there are many resources within chiropractic for that sort of thing. Okay, we've got 4.5 minutes for questions. Hopefully that'll be sufficient before we go to tea. I promised who had a question up there. You're okay? We covered it? Okay, great. Super. What doesn't seem right about this?
Up there.
Seems kind of right, actually, if you think about it, now that you know how things work here. And once you put it in your chiropractor framework, it's like, well, yeah, we can help these people.
Doc, just to state the obvious, obviously within pain-free limits. So the walking aggravates the pain, they can't walk.
No, I'll have them get up and walk. Anyway, they're going to have to walk to the bathroom. Whether it's painful or not, they're going to manage it.
Even if the neurological signs get worse, the more they walk?
Yeah, so I will check that on return visits, but I don't mind if it temporarily gets worse. As a matter of fact, on very acute patients, I will temporarily use a lumbar corset because that will help to at least get them upright. It removes some of the pressure, the gravity pressure, and then it allows them to do this movement process. Yes, if they absolutely can't walk, I'm not going to try and drag them out of bed and make them walk. But as I said, they're going to walk to the bathroom, and so walk to the bathroom and back a few times. And so start slow and give patients appropriate goals. And so I will usually have a patient just start with 10 minutes of walking. Just walk for 10 minutes. That's not a lot, but to somebody with an acute disc, that seems like a lot. And it can just be around in the house. That's probably safest for them. Just go out the front door, walk 5 minutes one direction, and walk 5 minutes back the other. That's relatively limited, but then try and do that several times during the day. They probably aren't able to work at this point, so my description to the patient is, I would say, your new job is getting your spine healthy. Your new job is getting better. I realize you can't work. That's why I've signed your, if I signed something for a patient to keep them off work, then I definitely I said, your new job is getting healthy. And so one of those things you're going to do, I'm going to ask you to walk for 10 minutes 3 times a day. I don't care when you do it. I don't care if you can't do all 10 minutes, do 5 and do it 6 times a day. And so, incremental exercise like this is fine. We don't have huge goals at this point. We just want to get that area mobile. And so the sooner we can do that, get the lymphatics draining, get the circulation to the area, the better the patient will feel. And so in my experience, within a couple of weeks of following a program like this, they're not even considering having surgery. And so it's great when you've got orthopedic surgeons that have a 8-week or a 12-week wait list because it's built in there. They can't have the surgery, and so you've got a chance to work with them for a while. And I, based on my experience, the experience of many chiropractors I've talked to, and based on the research we have, 90% of those patients will be able to avoid surgery. Maybe more when they're under chiropractic care. Marius, yes?
Did the study say anything about the loss of surgical income to the surgeons?
Yes, this is somewhat. They may have to retrain to do something else. Maybe they can do hip surgeries. Apparently, I can't do much of anything for FAI and that sort of stuff. And apparently, there's a need for people here to do FAI. So there's a demand for that. If we can decrease the demand for disc surgeries, maybe they can find another line of work. Thank you very much, folks. I appreciate it. We'll be back tomorrow. Peg's going to talk more after tea.
Thank you, Dr. Highland. That was fantastic. Thank you. We learned so much there. Guys, just a couple of little gifts. I don't know if anyone wants a gift or two. We're going to just draw. We've got some Iceman tubs to give away, and we also have a night at a 5-star Irene Country Lodge, if anyone wants that as well. All right. So Dr. Dickinson's gonna. This is for the Iceman. We have five packets to give away.
Dr. Gareth Hardy.
Not here? You're not here, you don't get. Okay, pull another one. Yeah. We've got a team effort here. You got?
Lloyd Clark.
Lloyd. Well done.
Dean Wilson, Dr. Wilson.
Okay, cool. Put it back.
Oh, back in? Oh, okay.
Barry Stranick. Yeah. Okay.
He's on the webcast. Bad luck, Barry.
Devlin Randall Smith. Dr. Randall Smith.
It's the second one he's got. How many have we done?
Mihad Sidat.
Okay, is that all? We've done 5. I think we've done 1. How many have we done? Lise? How many guys have got? 1, 2, 3. Okay, let's go. Another one.
Ashley Deal. Dr. Deal.
Sorry. Tammy Lewis.
Okay, good. Tammy Lewis. Ashley, come get some Iceman. Thank you very much to Allura Pharmaceuticals, should I say, not pharmacy. And Peter, thank you very much for the gift. All right, I think for the slightly bigger prize today, It's one night stay at the boutique 5-star Irene Country Lodge. We've got another one tomorrow for a 2-night stay. This is bed and breakfast. Tomorrow's will be dinner, bed and breakfast for 2 nights. And here we go, Zaina Taraz. Yes. Well done. Well done. Give him a hand. Cool. Guys, please scan out and go have some tea and then... No scanning out. Apology. Just go and enjoy your tea.